It used to be said that my greatest accomplishment was the things I've done in my profession. Does anybody sail a boat? And wow, I'm in Florida. There we go. I've got one person who's going to commiserate with me on this. My greatest accomplishment now is that I successfully shot the Gulf Stream and did not end up in Virginia when I did it, because you got this current out here that just goes like a freight train. And we had to go all the way down to, we came from St. Thomas, Virgin Islands in a catamaran. We got all the way to almost Havana, and I almost turned left instead of right to go across. If I'd turned left, I wouldn't be here today. Hey, Texas brings their greetings. It's good to see meetings happening again. We just finished our South Padre event in waters very similar to yours at what's going to become a Jimmy Buffett Margaritaville next year. And we had a very good turnout. Unlike the Florida Society, and don't egg your president, we didn't charge for the CEUs. We just charged for the food and beverage. We gave the CEUs away. So we took a big hickey, but it was our first meeting in 2.5 years, and we decided that we could just wait until the bruise went away. We are coming to, we're having our summer meeting in Galveston. I have invited the president, but I will extend that to the board to come, and we'll waive registration for Florida board to come and see how we do things. And I know you guys are probably hiring. I saw some recruitment booths, but we're like desperate. So if you really don't like Florida, talk to me. You can come to Texas. We have sign-on bonuses also, and our money goes a little further. So without further ado, I am what stands between you and lunch, okay? So let that be our call. There are a couple of things. Yeah, I'm from Houston. I have to make some disclaimers. This is a sponsored event. As such, I will do my best to not induce bias, okay? But a lot of what we're going to talk about has to stay within FDA guidelines, and a lot of what we do with inhaled drugs, especially vasodilators, is off-label. I can touch on off-labels from here. We can talk about them personally later when I'm no longer part of the talk, if you have those kinds of questions. It is an educational CME program unless you're from, I think it's Delaware, and then you can't get food with the CEU at all. It's an OIG thing. The information is consistent with all FDA guidelines, and it's for educational purposes. And most importantly, Mallinckrodt's doing this out of the goodness of their heart. They are not asking you to go buy their devices, okay? And I am not a paid employee of Mallinckrodt. I'm just part of their Speakers Bureau. Your sign-in sheets are being handled by your state society sign-in. That's been incorporated that way. You do need to make sure they've got all the information for that. So we're going to do 4 things today. Did anybody do this talk with me at the AARC Congress Live online? We did this thing during like the noon hour a couple of times. All right, we're going to talk about inhaled drugs and devices for mechanically ventilated patients. We're going to discuss the physiological challenges of doing aerosol or delivering drugs via inhalation. We're going to compare features of different types of systems, and we're going to talk about safety considerations and monitoring when using them. That's really the 4 things we want to accomplish here. So, why administer these drugs? We want to get a local and or a systemic side effect. What determines where the drug is going to work is determined by the pharmacology. Delivering via inhalation. So for instance, if I gave a patient IV amikacin, I would get a different result than if I gave them inhaled amikacin, correct? If we give the IV amikacin, we don't gum up the expiratory side of the ventilator, but they don't get the result you want. If I give them inhaled amikacin, you get the result you want, and you get this big old puddle of goo on the expiratory side of your ventilator you've got to figure out what to do with a couple of times a day. Inhaled drugs with short half-life may have fewer side effects, and the onset of effect of inhaled drugs may be faster than with oral dosing. So if you think about that in terms of vasodilators, nitric oxide is certainly going to have an effect faster than Cialis would or any of the tablet forms of vasodilators. Remember, that's what they're for, right? That's actually what they're for. They're for vasodilation. That's exactly what they do. All right, what are the types of drugs we do? We all know some of these, right? We've done an ocean of albuterol. We've done 2 oceans of mucomist or hypertonic saline, or both. We've done anticholinergics, ipratropium bromide, and all of its precessors and successors. Some of us remember drugs before that. Inhaled pulmonary vasodilators, which is, I think, certainly where the market focus ends up being on how to do this, because cheap, kind of cheap, cheap, not so cheap, okay? So economics takes a place. Corticosteroids, which we don't really do that much because, fortunately, science has proven that, at least in acute care, inhaled versus systemic really don't show any difference, so you can actually just give them the pill. And antibiotics, and that's certainly, we see that, and then we try to chew our arm off getting out of having to do it because you have to do it forever. So we do this, when we do this, we normally have a clicker. So by show of hands, if you're bold enough, who does a whole lot of bronchodilator therapy, aerosol, post-COVID? Is anybody going to raise their hand? Yeah, this is what makes people nervous because we quit doing a lot of inhaled aerosol therapy with COVID-19 because it was an aerosol generating procedure, and I didn't want to be that guy who made a nurse or a fellow worker get sick from COVID-19. So the aerosol drug market for bronchodilators, mucolytics, anticholinergics, and steroids and antibiotics has probably gone down. Who learned how to do a whole lot more inhaled pulmonary vasodilators? I saw a hand shoot right up when they saw that one, okay? So people have started doing more of that. That's why we're here to talk today. So what are the types of devices? MDIs. Does anybody do MDIs? Can you afford them, the HFAs? Or do you get out of doing them, right? Because the hospital price is a special for the 30-day supply that's at least as much as the patient would pay at a pharmacy. It's not a knock, it's just the truth. Jet nebulizers, we use a lot of those, right? Tell me who does mesh nebulizers. There we go. It's called the aerogen effect. Okay, you turn that little switch on and you see that cloud and you're like, oh, tell me more. And then who has inhaled nitric oxide delivery systems? Adult and or pedi, neonatal. Okay. So we'll skip past that. The good news is there's a bunch of these in here, so we'll kind of do some for hand raising and let some go. So MDIs, small, portable, they fit in your pocket. They often go home with you. They're not supposed to. They just inherently end up on the center console of your car when you figure out it's still in your lab coat. Self-contained delivery system, portable, light, compact. If you have the right circuit, you can do it. If you have the right tool, you can use the new HFA inhaler. But you realize that the tool that they make to fit the HFA inhaler with the counter in is actually not cleared by any of the manufacturers to use, so you really don't know exactly what dose you're giving. We are very good at doing things because we can and figuring out ways to get around doing things, but sometimes we really don't know what we're delivering. You're going to see that come up a lot during the next few minutes of conversation. It is a short treatment time. Whatever the dose you might be giving in line on the ventilator is reproducible. You just don't know exactly what it is. You don't have to prep the drug. It's not very easily contaminated unless you take one inhaler between a bunch of patients, and then that changes the whole story, which is why we don't do them anymore. Jet nebs in line. Who does those? Who takes a neb and puts it in line and turns it on a flow meter? Anybody? Yeah, nobody saw any hands go up. They're going to say, no, I'm not going to go there. Not going to be part of that. So the problem with this is what we do. Doesn't cost very much. You can do whatever dosage you want. But on today's ventilators, putting that nebulizer in line, if it doesn't have its own nebulizer port, adds significant flow to the circuit. Now, if you do kids, you can really hurt them, okay? And if you do grown-ups, you can bend them pretty bad. You may not break them, but you'll bend them. because that 6 or 7 or 8 liters a minute of flow going into that circuit is significantly increasing tidal volume. 8 liters a minute is about 220 cc's at a rate of 16. Just do your math, figure out what your minute volume would be, and you're adding that if you're using some volume mode. If you got newer, fancier ventilators and you use things like PRVC, it really screws it up because the ventilator says, I'm not sending that much gas down the circuit, so it just keeps ramping down and says, finally, you don't know what you're doing, so I'm just going to make a lot of noise until you figure it out. So then we enter the mesh nebulizer. The newest generation. Thank you to Aerogen and everybody else who came up with it. It aerosolizes drug by agitating a screen that makes for a very uniform particle size that drops through, and it aerosolizes all of the drug. You don't have residual volume left in the nebulizer. And it mostly works, and sometimes it doesn't, and it gives you a little yellow light to tell you it's not. But you don't know that because if you're not looking for the yellow light, you don't see it. So when you come back in, you just figure, oh, that's humidified water. Now, here's the thing. Do you see where it's placed? Who puts it on the dry side of the humidifier? Because that's where it's supposed to go. Okay, it's been studied. And I just had Dr. Arzu Ari at the South Padre event who further verified that that's the best place to put them. It doesn't ring well with what we do, and if you use albuterol, the sulfur in the albuterol makes the water in the humidifier turn yellow. So then you're kind of on the hook. Do you either change that so you don't see it? And changing circuits is something we don't like to do anymore. Some of us used to do it every day, right? I see some gray hairs. So we say, oh, it's okay. And then the family's talking about the yellow water that's going to their grandma and grandpa, okay? It does happen. Nitric oxide delivery systems, as a general rule, involve some kind of a tank of gas because while nitric oxide is free standing in the atmosphere, you got to get a lot of atmosphere to get enough nitric to matter. And it, by some way, shape, or form, puts gas into the ventilator circuit, monitors the amount of gas going to the patient, needs to be validated for use in the ventilator, okay, because not every ventilator will take to nitric very well, and will give you drug delivery with some kind of alarm, with a backup drug supply and a backup power supply, which are all very nice things, especially in states where there are things like hurricanes. We share that in common. So what are the physiologic challenges associated with this? So this is kind of like objective 2. We want to target the lungs. That's what we're trying to do with aerosolized meds because we want a local effect, not a systemic effect. So for local targeting, drugs have low solubility or high tissue affinity. In other words, we put albuterol in the airway, the albuterol bonds right there, and if it gets the right receptor site, the beta-2 receptor site, students, it does the right thing. If it gets the alpha or beta-1 receptor site, their pulse goes up, their blood pressure goes up. Doesn't happen like it used to. To get systemic effect, the absorption rate must exceed the rate of clearance. So you got to give a lot of drug if you're going to do that to get a systemic effect. Probably more than the lungs can handle. The factors that influence it are half-life and delivery. Big one with delivery is particle size. Does it go where it needs to go in the airway? And what are the extrinsic factors? Emission from the device, so in other words, a pressurized neb, standard neb versus vibrating mesh. That's going to tell you a lot of what happens. And the solubility of the drug, remember we have solutions and we have suspensions, and getting the right particle size to get that to where it needs to go to. So what are the 3 ways that lungs process inhaled drugs? So 1 is by clearance, up at the mucociliary layer. 2 is by metabolism to the lung tissue. And then 3 is absorption into the capillary blood network. So let's use one that's took a while to figure out. Let's use salmeterol as our example. Salmeterol gets absorbed. A lot of these, especially long-acting bronchodilators, get absorbed into the adipose tissue in the lung for eventual distribution into the blood vessels. So that's how you can give such a big dose, because it's bound somewhere where it won't cause harm until its half-life breaks it down enough to become absorbed and go where it needs to. Dissolution and lung clearance, our cilia move secretions. That's why we do this, right? Somebody asked, describe what you do poorly. We make people cough, and then we suck snot. That's what we do when it all comes down to it. The mucus is either expectorated or swallowed. Glad we're doing this one before lunch, because if this was for nurses, they'd already be getting queasy, because all you got to do is go in the room with the suction catheter and they're getting weak in the knees. Never mind, you're in a C. diff room and they're in there cleaning them up, talking about their lunch, and I'm over here trying to find the trash can to... Smaller particles are able to penetrate mucus. So your mucus layer, if you have one, can become a significant barrier to the delivery of drug. And what about the macrophage? The alveolar cell recognizes that it's not supposed to be there, so it actually attacks it and takes some of it as well. That may not always be a bad thing, because it can translocate them, and then they internally degrade them, enzymatically degrade them. Drugs metabolized in the lung tissue, like epropostanol and inhaled nitric oxide, may be partially metabolized in the lung that they target. When the rate of absorption exceeds the rate of metabolism, it can lead to systemic effects. We may or may not be looking for that systemic effect. It depends on what you're doing this for. You can give some of these drugs, and they are metabolized in the blood. When the rate of the metabolism is slower than the amount delivered, you may get systemic effects. And lastly, where are most of these drugs ultimately metabolized out of the body? They either go through your kidneys or they go through your liver, and these drugs, a lot of them go through the liver, and you can actually detect levels of the drug in their blood and their urine. So, which of the following pathological lung conditions could affect drug absorption? Acute lung injury? Probably. You got those nasty, swollen epithelials that aren't really happy with what's going on, and cytokines running around trying to figure out where the fight is. Severe pneumonia? Yeah, because now you've got VQ issues. Acute respiratory distress syndrome? Well, A is going to lead to C. So you get B, you go to A, you end up at C. So all of the above. What about pathological lung conditions like chronic bronchitis and cystic fibrosis? So those can decrease the effects, just like emphysema. Why? Because as you sell all your condominiums and turn them into a warehouse, you don't have near as much space to get pulmonary uptake of a drug. So when your emphysematic patients tell you they have to hit that inhaler more than you tell them, just remember, they might actually be a little bit right. They probably shouldn't hit it the 200 times a day they hit it, but they do have a basis to their argument. Truth is just a varying level of degrees, right? There is all things are true to some extent. It's just how much you stretch them down the chain to get there. All right, so having done some background work, what are the special considerations? And this is going to end up mostly being on vasodilators. Intermittent delivery, short duration, exposure over a few minutes. We could do continuous delivery. You use a lower dose, longer duration. Or we do a single metered dose. So when we do an inhaler, if we have it out at the circuit Y, and we actuate the inhaler during exhalation, how much drug does the patient get? 0, or close to 0. So timing matters, especially in shorter doses. Intermittent delivery, how much of our medication gets lost to the room? 50% of it, because you only breathe some of the time. Depends on your IE ratio, but a lot of your drug goes out and back out to the room. Continuous delivery does the same thing, but because you're doing it continuously, they get more drug over time for that reason. So who does a lot of continuous nebs? Who does anything they can to get out of having to do continuous nebs? Who thinks a continuous neb is running back by that updraft nebulizer and dumping some more medicine in it about every 15 or 20 minutes? Okay, that's so that defeats the intent, but we do a lot of that. The PMDIs, we talked about these things because this is no longer an accurate picture. You have a counter, you have an ethanol-based solution in there with a non-CFC producing gas to get it out of the chamber. The fun thing about these new HFAs is that we all know there's a whole lot of medicine left in the ones that don't work, isn't there? And when it gets to zero, zero means zero. It means you might get some more out of it, but you don't know how much you're going to get. Don't rely on it. So we chuck a whole lot of Everclear and a little bit of drug in the trash can and move on. Because of how we do ventilation and how many puffs we do, delivery is going to be inconsistent. As we've said, timing of actuation can reduce a whole lot of mass. If you don't shake the canister, they don't get the drug, they get the propellant. The design matters. If you use a parallel circuit, parallel-wise circuit, one of the leading humidifier companies' primary circuits, you can't put the spacer in there to actually give the drug. Where you place it matters. If you put an MDI way back here, how much is going to get to the patient? I have no idea. Probably none. Heat and humidity. So aerosol drug delivery can be reduced by up to 40% in heated and humidified ventilator circuits compared with dry circuits. But I will tell you that Texas State just did some work by scintigraphy. They actually radio labeled, and they actually found better deposition of drug in a humidified circuit than in a non-humidified circuit by aerosol. So there's still something to be said about the stabilization of the aerosol particle and the density of the gas and how fast it's going, okay? Intermittent delivery, we commonly do with bronchodilators. You know, you put it in a vibrating mesh neb, it runs for 30 minutes, but the drug's all gone in 10, it shuts itself off. Really makes your life good. You didn't leave that thing running inline on the ventilator circuit and wondering why the apnea alarms are keep going off or anything like that. It shut itself down. In a updraft neb, you can have up to a couple of cc's of your dose still there, still not doing anything, except sitting in there for the next person, because we all know we're excellent about draining the extra medicine out of the cup, rinsing it with sterile water and placing it out to dry like the Joint Commission says we're supposed to do. Everybody nod your head yes. Who's been through a Joint Commission lately? And did they look at anything like that, or did they get hung up on the other end of the spectrum? Thank God, okay, because we just went through ours. Because, yeah, I don't know how that would work. I really don't. So back to the nebs. Standard jet neb. This is the Hope neb. This is the idea that you can do continuous with a jet nebulizer at lower flow, vibrating mesh, and then an ultrasonic. Not so many ultrasonics, primarily because they're harder to get in a ventilator circuit. But who's doing inhaled vasodilators in the hospital? And what are they all using? They're all using ultrasonic nebs. It's an incredible number of steps in the procedure to get these patients some of these drugs that they've got to take every 4 hours. And, you know, you remember the clip from House where he asked the asthmatic lady if she knows how to use her inhaler, and she says yes, and then she sprays her neck, okay, like it's perfume? Think about that with people with pulmonary hypertension who are struggling to breathe on a good day, and the number of steps they have to successfully negotiate to be able to do an ultrasonic, because they have to add water, and then they have to put medicine in the cup, which has to have a certain part of it exposed to the water for all of that aerosol to occur. Not saying they're bad, because Lord knows we've done enough ultrasonics. Anybody ever touched the plate to find out what happens? Get students to get an ultrasonic, get a student to touch the plate. Please, at really low power. I don't want to really hurt anybody, but I was that guy that said, oh, it doesn't hurt. Yes, it does. You'll only do it once. So continuous by jet neb leads to high residual volume. There's another effect to this besides the flow in the circuit. And a big key is that variability in some of these nebs is as much as 15%. So, and that's moment to moment. So at any given moment, you could be giving from 85 to 115% of the drug based on its function, and that's by nebulizer. And when you finally figure out that dose for the patient, and then that nebulizer falls out and hits the floor, and you get another one, you get to start all over again. So there's 15% is probably significant enough variability to make you think about what you're going to do with that, especially when you're talking about more of the vasoactive type drugs. It's got to go out at the Y. Everything that goes out at the Y has to stay upright, correct? And that works real well when we're rolling patients from side to side and changing linen, and you come back and your neb that you went to a lot of trouble to put 15 cc's of drug in, and you come back and it's empty. Well, now you've got this ethical dilemma. What do I do? Do I say I gave it all because you probably lavaged them with it? Or do I start all over again? You know, we have these little mini ethical dilemmas every day at work that people don't know us and what we do. We need to educate them on that. More importantly, if it doesn't work, it doesn't tell you. And if you're feeding it off of a bag and it's not working correctly, it just keeps feeding because the bag has no brain. It just tells you to do whatever. If you're running it through a pump, the pump's going to run until there's sufficient back pressure, but it's an open system. You're never going to see it. So you're going to have a lot of variability. I wouldn't want to do that with a vasoactive drug. I probably shouldn't do it with bronchodilators, things like that. But if I'm using a drug to keep somebody alive, I should probably be a little better at it. So chalk that one up there. Mesh nebs. They have a low residual volume. They don't get contaminated. They deliver a consistent dose. And the effect of the drug, because it's vibrating it through a tiny little hole, doesn't denature the drug. Some of the things we do to drugs cause them to change their function. And it works better, but it still has no backup system. And if you're doing this and you're putting your bag of vasodilator here and your bag of diluent here, and you're feeding them to a pump that then goes to a patient so that you get continuous nebulization, what you have is eye candy. Because if you're coming down here and coming down here, you don't know if those particular drops hitting the nebulizer are some of the saline or some of the drug. But if you look at some of these patients, you'll know it because you'll see it on the monitor. I saw this in patients with VADs as we first started doing our first ventricular assist devices. And they're really susceptible to flow differences at an RPM. And we tried using some inhaled drugs, and what we saw when we did that is that there were periods when they weren't getting drug that their VAD flow was very low, enough to trigger alarms, followed by getting a pretty good kick of the drug and getting a big flow. They were happy they were tired. They were happy they were tired. They were happy because there was definite peaks and valleys in that. So it's a consideration. If you're going to do that, you got to kind of figure out what you're doing, and you have no backup. You'll accumulate aerosol. You pray that it works because it doesn't tell you it doesn't except for one little visual indicator. And that becomes that. So what about gases? So because we're doing a vasodilator, NO is probably the vasodilator of choice. What's the best vasodilator we know of, folks? Oxygen, right? That's actually the one that gets you going when you're born. Causes things to close, causes blood to start going the right way, turns you from a fish to a person, and off you go. NO systems require a pre-use setup. You need to make sure they work. There's a lot of training involved. Who remembers seeing NO for the first time and trying to figure it out on the fly? Yeah, not so much, okay? And then you want like this flow and then do this and then do that, and then somebody called you and you forgot where you were, so you're back to the start. And the doctors are saying, I need it now, and you're saying, I'm working on it. It just takes a little time. You know, they're from the hospital where the doctors do everything and it all happens right now. When they need that stat CT, they're running down the hallway while they're doing compressions to do that CT, right? And they have a large footprint. They take up space in the room. And nurses love it when we take up more space in their rooms, don't they? What are the effects? Depending on the device, the calculated the NO concentration can vary with changes in your ventilatory pattern. You're putting gas in a circuit at higher minute volumes, you got to put more gas in the circuit. The response time of the device tells you how fast it can do that. At lower minute volumes, i.e. infants, you don't put much gas in the circuit, and the machine has to figure that out. So monitoring and dosing become very important factors, because what happens? What happens if NO2 goes up, folks? We always worry about it, we set alarms for it. But what are the two worst things we can do if we don't do these gases right? One is we can give them methemoglobinemia. Y'all check regular methemoglobins on patients, right? When you do this? This is where you nod your head, yes, please, okay? Yes. You monitor your NO2 buildup because NO2 buildup is going to have a pretty direct relationship with your methemoglobin production. And if that isn't enough, not just NO2, you can end up with the wrong delivered concentration going to the patient. So monitoring matters. So we're going to talk about monitoring. See how that works? In your experiences, are inhaled drugs administered intermittently more often than continuously to vented patients? Let's rephrase that. Who does continuous delivery? Who does intermittent delivery? If we're talking about primary vasodilators, do you do continuous? Okay. Do you do any intermittent? Once in a while, try to turn it back off, turn it on, try to turn it back off, turn it on, try to turn it back off. Get the little baby down to 0.1 part per million, and then turn it off, and they crash and burn, and you're back up to 0.1 part per million. They really become physiologically dependent on it. So, I ain't never done continuous mucomist. I try not to do mucomist, okay? It really doesn't work the way that the doctors think it works. If they have a liver overdose and you can get them to drink a cup of it, if they have a bad liver and you can get them to drink a cup of it, it's got some protective qualities. There's arguability that it may do something in burns, but I ain't gonna do it continuous. Corticosteroids, I'm not going to do continuous corticosteroids either unless they're going through an IV bag into their arm. Short-acting bronchodilators, you may do continuous. Long-acting bronchodilators, absolutely not. And most patients, when we get them on the vent, we don't do long-acting anyway, right? We just do short-acting. They're here for an acute condition, not a chronic condition. All right, so who does continuous ipratropium with their albuterol? I'm going to be the only brave soldier to raise his hand here, right? It gets mixed. It's in the NIH guidelines that they should get some. So a lot of times we do continuous duoneb. So you're doing continuous anticholinergics. The non-steroidal anti-inflammatories, yeah, I don't go there. Antibiotics, we don't do continuous, but we do a lot of intermittent. And short-acting pulmonary vasodilators. Continuous use, but you need to monitor your drug. Most of this other stuff we don't really monitor anymore. When's the last time anybody saw a patient get tachycardic off albuterol? Never, okay? They find, now for those of us in the room, who remembers giving isoethrin, doing bronchosol? You'd be 3 minutes into that nebulizer treatment, patient look at you, go, I'm breathing better than I've ever breathed, but God, my chest really hurts, okay? And then you look up at the monitor and you're like, oh, we're done here. And you try to kind of turn that down and hope everything goes back to right. So why is it necessary to have alarms to alert clinicians in pulmonary vasodilation delivery? Why do you want to know? Why should you care? Is it because suboptimal concentrations can interfere with airflow? Nah, that's really nicely worded, but it doesn't mean much. Are alarms just not necessary? Well, that's back to, do you really care if what you're given is working? If we're supposed to be the wizards of aerosol, we should care about how they work, right? Can abrupt discontinuation of pulmonary vasodilators disrupt humidification? Well, no, because aerosol is not humidification, it's aerosol, right? If we learn nothing in 50 years, aerosol is not humidification. Molecular water is humidification. Ask the guys next door, they'll teach on this, okay? Because abrupt discontinuation of pulmonary vasodilator delivery can cause rebound pulmonary hypertension. Absolutely. You can go from, this is going to be a pretty good day, to, God, I'm never going to get out of this one, about that quickly, especially when somebody comes in and says, we're going to wean that today. I'm like, no, let's do that tomorrow because I'm off tomorrow. Well, why is this? Because rebound pulmonary hypertension takes a dilated blood vessel that had its vasodilator working on the cell wall. You take that vasodilator away, the half-life is measured in minutes, and you get really thickened and constricted blood vessels, and you go right back into your hypertensive state. To state it another way, when you get hay fever, what happens when you don't do your antihistamine or your corticosteroid you spray in your nose or whatever? Those really fairly nicely dilated nares of yours with those really special cells on them, those goblet cells tend not to be exploding. But when you forget to take your medicine, what happens this time of year? Yeah, you remember about the time it starts, I should have done that. So what's the FDA guidance? Let's talk about NO, because there is guidance on NO, because everything else we're doing is way off-label instead of just off-label. The mean inspired NO concentration should be constant during NO delivery and should not adversely affect triggering, cycling, alarm function, or any other aspect of the ventilator. Remember how I told you needed a ventilator manufacturer to tell you their vent works with NO? That's to satisfy that FDA guidance. Sensors maintain proper levels of NO and nitrogen dioxide and have alarms to warn clinicians if these gases fall outside the safe clinical range. So that's why that's on the screen. Backup systems. There should be a backup drug supply and a backup energy source. There should be a battery, because we forget to plug things in once in a while. There should be a backup drug supply. That would be turning switches from a actual measured dose delivery to a continuous dose delivery to make sure that they get some of the drug, remembering that it's qualitative in cases, not quantitative. And the ventilator compatibility, so that goes with the operation. The ventilator should be tested by the manufacturer to make sure that it meets all of those. So what is ECRI? This is an institute, it's a nonprofit that is dedicated to bringing the discipline of scientific research to determine which medical procedures, devices, drugs, and processes are used to implement patient safety. There's over 5,000 members. Your hospital may be one, or your public health system may be one. And they release alerts through their alert tracker, kind of like the FDA warning system, to let you know that things aren't right. And here's what they've come up with for those people who are doing inhaled ibuprostanol. There's a source of clinical error because we don't know what the dosing is. We're flying this one by the seat of our pants, so we give some ibuprostanol. IV dosing is lower than the inhalation dose, so if you go with an IV dosing first starting off, you're probably not giving enough drug to matter. If it's inadvertently, wow, I was going to have trouble with that, given to the patient's IV, they get a much higher dose, which is going to cause some problems. And we know that nurses have never hung a bag of our medication or used a bag of sterile water on an IV ever, because we've never seen that happen. We're all perfect. Just doesn't happen. Not picking on nurses. Love my nurses. But things happen. There are safety concerns with drug delivery because there are no alarms in our custom winged setups. So when I've done it at our house, we didn't use a diluent bag and a drug bag. We used a drug syringe, actually divided in half, running through 2 vibrating mesh nebulizers, so that if one of them failed, we were still giving 50% of the drug. All of those cost savings that we thought we recognized from doing that, because this is what happened when I did my first VAD, and the doctors were used to doing inhaled ibuprostanol, and I said, oh, this is very bad. So I tried to take the peaks and valleys and kind of try to smooth them out a little bit. It did, but it was very cumbersome, awkward, and expensive. So we just went to NO. If we're going to spend the money, do what you need to do. Due to the sticky properties of the drug, you can clog up your exhalation valve, depending on manufacturer. And sometimes your ventilator just says, yeah, I'm done with you, and shuts down. If you're really lucky, it alarms to tell you it did that. That seems to be a growing trend in the industry right now with the letters going out. We may have issues. So the recommendations were document the decision rationale for off-label use with supportive research and informed consent wording. Who does that? We do off-label stuff all day long. And we don't go to the patient and say, hey, I want to experiment on you, or this is off-label, because they'd say, I don't want that. And well, but it's going to save your life, okay? So we don't do that, but that's the recommendation. Monitor and report adverse events. Listen, I do this whole talk on reporting. Who's done more than 20 variances in their career? 10? 5? Okay. Done more than 20 in their career, and I see some old-timers out here. So the answer is that we should variance a lot of things and we don't variance them, right? For 2 reasons. One is it seems we feel like it gets us in trouble. The other is that it's going to lead to a solution that's probably unworkable in day-to-day life, because you're going to let people who don't do this stuff decide what the fix is going to be. So we tend to just kind of move on. Remember those little ethical challenges we face on a day-to-day basis? We're supposed to report our variances. Variancing yourself is one of the hardest things you'll ever do. So what's the take home? Believe it or not, we're done in time and it's about lunch. There are a lot of ways to deliver aerosol meds to mechanically ventilated patients. We know that because it's what we do. Each device has a unique set of challenges, which got to be weighed against the potential benefits and risks for the treatment of each individual patient. You know, we go through our lives trying to loop patients into one category, and the reality is that every single one of us is different in this room. Why would we expect our patients to be different? The properties of an inhaled drug and how that drug is cleared from the lungs are safety considerations when selecting an inhaled therapy. Absolutely and positively. If you have a patient who needs a liver, should you give them a high dose of something that their liver is going to have to process? Probably not. So you do have to think about what you're doing and why you're doing it. Delivery of short-acting vasodilators requires additional monitorings and safeguards. So here's the Russell take-home. There's this guy. His name is Simon Sinek. I don't know if anybody's ever watched him. But he does a lot of really good, clear thinking. And he has what's called the circle of trust. It's the circle of why. As a profession, we have spent a lot of time learning how to do things and what to do them for. And our educational system today teaches that to the students. But what we don't spend time thinking about is why we're doing it. And the how we do things should affect the why, not the what. So coming from the Texas Society, where I have a gazillion vacancies, job vacancies in my state, to Florida, where you have a gazillion job vacancies in your state. I know that because everybody over there is recruiting. Might apply for my Florida license this week. Folks, we have to think about why. We do things because they cost less to say we did them. And I would challenge you to think about how that works for your own family member. When you go to healthcare and you see somebody cut a corner, when you access healthcare and you see them cut the corner, you're not very happy about it because you know what they should have done. So those little moral dilemmas we face every day, we need to choose to take the high road, which is a longer road, and it's got infinitely more speed bumps on it. But if you look around this room, you see about as many people like me with gray hair or no hair as you see people without gray hair and lots of it. And that means that some of us are on the trajectory to retirement. And how many students are in this room right now? They have a student track. You don't even let them into your house. Okay. Yeah, they got to learn the hard way. You know what? Here's the challenge to that. They don't learn the hard way. If you don't bring them in because they're millennials, and I didn't do this. I'm a baby boomer, okay? But I did do it to my kid, and my kid in turn did it to post-millennials now. They don't respond that way. You got to bring them in. You got to sit them down. You got to give them a participation trophy, all right? I was raised on the tenet that there is no trophy for 4th place. Hell, there's a trophy for 99th place, okay? Everybody gets a trophy. We got to find out what makes them tick because, folks, they're the next wave. And somebody's got to take care of me. I'm probably not going to be on a vent. But somebody's got to take care of me when I need it, and I'm not seeing that. And I teach for one of the universities in Houston as a side gig. I'm a clinical instructor, and getting them to engage is nearly impossible. It takes a whole lot of time. So what are your questions? I think that's the talk. Yes?
When I developed our ECO program for our ventilated patients, I had a very strict protocol. We use mesh masks. It's done through syringe pump. RTs are the only ones that do it. We do all that. We had a very, very, very strict guideline for it. PF ratios were measured. Everything was, we wrote everything on the windows so everybody was safe. It almost turned into life support because I was having problems with physicians going, okay, I've already went. We can't go any further. It's not helping. Our PF ratio went from 50 to 60. That didn't help me. Nothing's working. We need to take this patient off the med. Okay, well, then they went, well, it kind of went up a little bit, so let's just leave them on. So I have people on there for days and days and days and days and days. It does not help. We're looking at them going, this is the protocol. We have to follow our protocol. And if it says in the protocol, if you don't see an improvement within 4 hours, blah, blah, blah. I mean, this is very, cut and dry. But it needs to be weighed down and basic. How do we sit there and get that through to a physician's office? And you know what, I understand, yes, you've got the medical director degree behind you, and we are the RTs, but this is the protocol everybody signed off on. We all agree on that, and it's not being followed.
You pray that COVID-19 goes away, okay? Listen, I have kept NO on COVID patients because it took their PO2 from 67 to 71, okay? That was a huge 10-point gap marker for the physician. So this is the moral dilemma from the doctor's side. They don't really know anything more about what they were doing, especially with COVID, than we did, okay? And I did an atmosphere of NO, okay? I'm the world's largest NO account. It's not why I got to be here today, but I routinely went through 100 to 150 tanks a week, okay? Yeah, a week. And that was sometimes on twice weekly deliveries. Everybody got NO because everybody inherently oxygenates a little better. And when people are dying of COVID, I don't care if you've been vaccinated or not. That is your choice. But I'm going to do everything I can because I got to sleep with myself. I got to look myself in the mirror. And I got to be a reasonable resemblance of a human being to my family members. I don't care what the rest of the world thinks about me. But I've got to be able every day to say I did everything I can. And in some way, shape, or form, I think a lot of physicians hit that same point. And so with COVID, nothing worked. People died. Horribly, horrible death. My filter broke completely. Before I intubated people, I asked them if they wanted a minute to get right with their creator, okay? I don't know what you call your creator, but this may be the last time you have that opportunity to say it out loud, because my mortality rate during Delta was 80%. If I put you on a vent, you were either going to die or were going to wish you had. So I didn't care how much NO cost. If it made a little bit of difference and could help turn a corner, let's do it, man. And we learned a lot about what vasodilators do, and I learned a lot about heart function, and that's something we don't pay enough attention to is RTs, okay? Forrest Bird will tell you that it's the cardiopulmonary system. Well, Forrest would tell us, he's telling us, okay, now, that it's the cardiopulmonary system.
You were going to be with all these tanks, did you restrict it for oxygenation, or there a crossover with cardiothoracic patients?
A lot of crossover. So we did not do a lot of cardiothoracic surgeries. During most of the waves, our elective surgeries went down. But we did see a lot of people respond because they needed the right heart support. So when we talk about cardiac function, you got a left heart, that one's real easy. Don't have so much salt on the ham, okay? But the right heart's a whole different beast. That's why it's cor pulmonale, it's why it gets its fancy designator. Yes, sir.
Staying the topic of cost, I've had a lot of people from the billing department estimate regarding the actual cost and the implication and all that stuff. Have you had any issues with rejected claims? I've had a lot of issues in the hospital where the billing department estimates that you need something to show the insurance company that simplified, obviously there's no indication for active adult use. So we use it for COVID, ARD, so we're right now dealing with a lot of rejected claims.
You have patients with insurance? Okay, see, I don't. I'm in Texas, guys. 40% of my patient base is 60% is totally uninsured. Most of the other 40% are dramatically underinsured. So the quick answer to that is, it's off-label. They're not going to pay for it anyway. I don't know why they're bugging you to consider it, because they're trying to bump up itemized charges. It's really not going to change the effect. Work on the cost side, on the supply side, and make it something that the billing office isn't quite so, they don't want to let go of that great big number they see that they could try to go after. And that's all going to be coding. Yes, sir.
How did you manage 150 cylinders a week? I mean, I pull my hair out of 40 a week. How did you manage that?
We have a big tank room, and we bought great big tank racks that hold 10 with straps, but it turns out I can pile 16 tanks on one of those stands, because I get 12 of them all the way around the outside strapped in, and then I start putting them sideways on top to go up and change them. We were changing tanks in our COVID ICU pretty much at the beginning of the shift and the end of the shift. And so, yeah, it's a big logistics problem. I will commend our supplier. We never got a notice they weren't going to deliver. I got a picture on my phone of our empty 160 tank run that we rounded up all the empty tanks. And it's funny because I got this little guy that does our deliveries. He's about 5'6", 5'7". He takes these tanks. Now, you know what a nitric tank weighs, right? They're really heavy duty. He takes one with his foot, holds it by the handle, kicks it with his foot up over his shoulder, takes the other one, kicks it with his foot up over his shoulder, and walks with a tank on each shoulder. And I just looked at him and said, "You're my hero." Okay? Because I drag these things along the floor and wake people up, trying to find a cart for him, and he can throw one up over each shoulder. So, logistically, it was a nightmare. Yes, sir.
Huge difference in the population that we serve, our preparing, but compared to the metropolitan Houston area, Harris County, millions of people. And hence why we may be going through that intense.
Well, and we were getting all the referrals. Yeah. And we were doing ECMO, so it's not just inhaled vasodilators. It's patients who went to ECMO, patients who were bridging to lung transplant. I can proudly say we refused to give up on any COVID patients. I can also tell you that we've still lost a lot of them, okay? And I remember them by name. And I hope there's a point in time that we get to sit down on the other side of life and actually get to know each other better, because obviously we had people of opposing political beliefs that were hitting the hospital, people with conditions. "Oh, you brought this onto yourself." I believe there was a politician in Washington the other day that said the government shouldn't pay for insulin because diabetics just need to lose weight. Okay? This was my message to the Texas Society at our meeting last week. We spent the past election cycle plus talking about how we're different. Okay? We need to spend a lot of time talking about how we're the same. What you guys do here isn't that different than what I do in Houston. We all have the same struggles. We all want to see the same outcomes. Focus on how we're alike, and the rest will work itself out. Because, here we are at a mask optional event, but it's Florida, and Florida's governor has said you don't have to wear masks ever for any reason. We have politicized way too much. From those of us, and I commend you guys for surviving COVID, as we come out of the pandemic to the endemic phase and pray that it never goes back to a pandemic, remember to focus on what makes us the same and not what makes us different.